This presentation was developed by Matrix Dental Laboratory and Consulting. Tom Zaleske, consultant. Find me on Facebook. Just type in Matrix Dental Laboratory and Consulting and become a fan. I specialize in removable prosthetics, in fabrication, education, and consulting. Look me up. Today's presentation is about plane corrections for out-of-sequence fabricated prosthetics. And what I mean by that is, unless a patient has had a full upper and full lower denture fabricated at the same time, we generally find that the planes start to become out of alignment. They start to cascade in effect, because what generally happens is if a person has an immediate denture made against existing dentition, either on the upper or lower, we're then starting to chase the plane. And every time another denture is made on another arch, or another partial is made on another arch, or another restoration is made on another arch, we're basically chasing the plane, which is incorrect because they weren't fabricated at the same time. Over the years, I've been flustered by this and receiving a case that's not the planes are lopsided or sway back or so forth, and just decided that there is a way to attack the situation and offer to our doctor clients to comprehensively treat these types of situations and correct them. Some patients obviously are not going to be receptive to it because it would need more restorative work, but there are many that will, and we can also offer temporary type of procedures to get them through until they could afford to do it. Anyways, let's move on and take a look at a case we have here. Existing deficiencies in this full upper. This full upper is opposing some fixed work that was made out of sequence and an edentulous quadrant. The things that I see right away when I look at this, of course, is that hanging cuspid on the patient's left-hand side, and I see a lot of pink. I see a lot of pink because there's no progression, there's no curve. It's rather flat, and actually it's very low, and as we'll see in a second here, I think that'll play out. I also notice that this cuspid tip is lower than this cuspid. It's almost resting on the lip, whereas this one isn't. And that side there is edentulous, and I believe that is probably the reason why. As you can see here, the edentulous quadrant, and you can see that tip is lower than that tip. And although this does have a curve, this curve here does not follow that same curve, because it has to be in contact with a deficient sway back type of ceramic bridge. The pink, again, just to illustrate, too much pink. I feel that we need to expose more tooth, and the rules for showing pink is only a certain amount, and I believe that the way that the teeth are framed in acrylic is really not very aesthetic. Let me show you what I mean. If that's the existing picture, I overlaid it with this just to show you what I suggest in order to get a truer look, especially for older patients, because older patients don't have long pointy papillas, they have short and blunted ones. Well, short and blunt angles are also order of the day, because if you keep these shorter, then this would be more white underneath, and it would do that all the way through progression. Same thing on this side. I also sketched a red line just to show you that we should be following the lower lip line with the incisal edge course, because that is actually the most aesthetic way to set teeth. It's the most aesthetic look, and it also helps to develop that curve that we're looking for. The blue lines illustrate what I'm looking to do with the incisal edges themselves in order to follow that course. It's just a profile on one side just to give you another illustration of when you don't have that curve developing, what happens is you show way too much pink. Obviously these aren't sculpted exactly the right way, but it's even more exacerbated by the fact that the plane is lower, and the reason the plane is lower because the out-of-sequence fabrication of that lower bridge, which is sway back. And again, I point to that cuspid over here on this side, which I see is hanging, and you know for a fact that that's because there was nothing set on the model when they set the denture up. Thus they eyeballed it, and generally what happens is they tend to be lower. And there it is from this side. Again, you can see, we'll excuse this. This was a repair, but this, and this, all of this is what the denture was fabricated to look like. Just not happening. I mean, there it is. Without that curve, you just can't, this won't disappear. Okay. Here's a frontal look, and what I did is I drew a line just to show you from cusp tip to cusp tip, and you can see the progression between the vermilion border and this distance is increased as we've moved across the face of the arch, and that's because we have nothing in opposition here. And again, we had no guidelines to help us set those teeth other than looking at them and eyeballing them. And over the years, I've gotten so many of these types of cases from laboratories and doctors who have fabricated them that way, and it's so flustering because we want to do a nice job, but the plane's already deficient. So got to come up with some way to fix it, and we're going to talk about that in a second. Here is that deficient plane, and again, this was lower here was probably fabricated. That bridge was probably fabricated against some super erupted teeth, I'm figuring. There was some wear that developed here. You could see it over the years. I don't know if this was the original denture, second denture, third denture, but you can see that this is sway back, as they call it, and really this plane needs to come straight across and develop a curve. We're going to see if we can't show the patient why we need to correct that, and also give the doctor some tools to do such. On the other side, again, just to illustrate, deficient, low hanging, here's the occlusal view. You can see we're working with a decent arch form. Here's a protrusive look with the existing denture in place. You can see how far open we are. In this position also gives us a good indication as to the fact that we need to build this area up either with a temporary or this needs to be a new restoration. Same thing on this side. It's just open mouth, more than a resting position. Just to illustrate the fact that this patient actually is a tongue thruster. It's going to be a bit of a problem. Ideally, that tongue should be laying at rest below the cingulums of the lower teeth, but as you can see, it's positioned here. Here's a nice firm upper arch ridge. No hyperplastic tissue. This was all palpated and checked, and because of the fact that tissue was in such great shape, I made a recommendation that we take the existing denture, fill it with hydrocast, and then let them function for a while, a day or two, and then take an impression inside of that denture, and then use that denture to mount the case before we pull it off the model. It gives us all the gives us the CRCO, gives us everything that we basically need. If the patient needs to be opened, of course we can put something on the occlusal to open them up to a certain position, but I believe the doctor felt that the vertical opening was adequate, and so we mounted using the hydrocast models. It's great. It's a great way to do it if you have some auxiliaries in the laboratory that can, or I should say in the dental practice, that can pour up models decently without locking in the denture. And if the patient and you have booking schedule time to do it, it's a great way to do it because you get a functional model. You can mount it using the existing denture, and it just gives you a great baseline to work with. If not, then this would be sent off. The model would be sent off for a rim, and then we would get that back and mount the case up with the rim and move forward from there. On the lower, I start to do some figuring. I usually take the model of the existing denture and place it on top, sketch out some lines, decide exactly if it's short or long, what I can do with it. Here I actually drew one plane in with the existing, and it confirmed what we had already speculated by looking at the photos, which is the fact that the patient's left-hand side dipped down, which it did. So then what I did was I thought that this side was good, so then I transferred that line across, and as it worked out, I worked that line across to the occlusal area of that edentulous quadrant and over the top of that short crown that's there. I use for this, I use the same brand of tooth and the same good teeth that I would use for the upper full fabrication, in the hopes that down the line we'll be able to make a partial denture using those teeth, and make sure that they all interdigitate correctly, and it just sets up a nice flow, because we're still going to use the same teeth, and everything is set up to lock in the right way. And on the other side we're going to make some corrections, and here's what I'll show you what I'm going to do here. And that is, I make these correctional indices, and this is prior to setting up the case. The correctional indices are made out of resin. They're made out of self-curing resin. I usually try to keep them in a tooth shade, as light as possible. This one here wasn't that light, but I'm correcting two places. I'm correcting that sway back bridge that we had, and then I'm also correcting that deficient crown that wasn't high enough, and to keep it in line with the plane. Again, I make it out of self-cure resin. I put a little bit of rubber sep on the model, make these, trim them up, put them in place, and then I set up the case. There's the case set up with it in place. Then this is sent to the doctor's practice, where it's tried in for intraoral evaluation, and then at this time the doctor can show the patient the benefit of why we would want to do that. There it is with the indices out of place. So as you can see, in place, out of place, and I would hope that the doctor would show the patient that take them on, take them off, and show. If these were partial dentures that were in opposition, if this was a partial denture on both sides and they were low, all I would do was suggest to the doctor to glue these, cement these onto the actual denture teeth, and use it as an interim platform in order to let the patient function off a much better plane. Again, in place, out of place. There they are with the lips. We now start to take a look at the framing by the mouth. This patient decided to bite and go along with some temporaries for a brand new bridge and two new crowns, so we were able to do that. This is the fabricated denture complete. These are the new crowns in place. She's not going to get a partial at this time. She's going to have implants placed, and then we're going to build a plane from there. She's going to have this work done and this work done and the implants placed, so she'll have a fully restored lower against a brand new upper full denture, which has all the planes exactly where they need to be. Let's take a look at what I'm talking about. First off, there's the finished denture. Here's the patient pre-op. You can see with all the deficiencies and all the problems. There she is with her try-in. At the try-in, I spotted this, which is a little bit higher up on the plane than it should be. I lowered this just a little bit. She likes some white. She wants something she never had, which was white teeth. That's fine. We'll accommodate that as long as it doesn't go outside the boundaries of looking natural. I still think they're in great position. So did she. There's her delivery on delivery day. The case is finished. As you notice, I made that plane correction. It's now lower. And then I got a post-op picture, a post-delivery picture about a month later, and you can see she's even more comfortable with the appliance now than she was. Again, I'm not real happy with the whiteness of the teeth, but again, there's not much we can do. This is what the patient wants, and we try to give them what they want without making it look phony. We have nice negative space. We have a nice incisal edge course. And all in all, it was a pretty darn nice looking case.